Every year, when we talk with our convening panel members, every year they say, you know, it is really great that we have a session with Republicans and we have a session with Democrats, but it'd be cool to get both of those two folks together and talk up on stage. And every year I say, yeah, you know, that would be good. It takes a special breed of legislator to be willing to go up in front of a few hundred of their friends and talk, debate, and be willing to get into the weeds on what is, in my opinion, perhaps the most complex policy area in state government, and that is healthcare. And so it takes a legislator who knows their stuff in and out, and also who has the confidence to admit when they don't know their stuff in and out. And that is unique. And so I am, again, so thankful and honored that at 2:30 or so yesterday, less than 24 hours ago, when I started emailing and calling, hey, I've got this open Keynote spot, who can you make, who can we figure it out? I will say that Nathan Johnson first said, whatever I can do to help you, the Chief Policy Officer of the Healthcare Authority, come on up. Thank you. Yeah. Senator Parlette said, I am doing everything I can to be there. I'm just not sure. I think I can take a 6 a.m. flight, and I think with my logistics, I might be able to get home by 1 a.m., but I'm coming over from Wenatchee, and I want to do it. Well, 6 a.m. flight got canceled this morning. So she got on another flight, and she got here. I had her tentatively lined up to be with us in the afternoon. When she landed on the ground here at about 10:30, I said, hey, guess what? You're going to be on our lunch keynote panel. And she was like, oh, great. Love it. So Senator Parlette, why don't you come on up? And I want to just pull up my email here from Representative Cody last night at 10:30. Let me see if I can find it here. Let's see. Representative Cody, tomorrow's lunch keynote has had to back out of us, ... This is 3 a.m. This is kind of what I'm thinking. Emails me at 6 o'clock. What exactly do you have in mind? If I do this, you are really going to owe me. Representative Cody, come on up. And I think, like you, that if I were to pick 3 people to talk health policy with in Washington State, these are 3 people on a very short list that I would want to get together. I'd love it even more if I could get them together on stage at the same time. And I'd love it even more if I could get them on stage at the same time with alcohol. So Nathan, from time to time, and I will get together for a beer, and I thought this would be appropriately one of those times, just to say thank you. When Representative Parlette and Representative Cody co-chaired the House Healthcare Committee in 2000 with a joint gavel, they had to work together to lead health policy, and they will tell you that from time to time, meaning every 2 weeks, they would get together for dinner and a couple of martinis and try to figure out how to lead their mutual caucuses. So just wanted to make sure that that was available to you if you wanted, which is just a way of demonstrating to you, first, my thanks. I think, thank you for your friendship and for your professional collegiality. I also want to just highlight that these 3 people have a comfort level with one another that would allow this sort of dynamic. It's a comfort level with one another that is decades in the making and truly unique, I think, for the betterment of Washington State healthcare. Though the theatrics and fireworks sometimes are more interesting, I think the collaboration and the relationships are pretty deep. So, with that, Sam, if you want to make sure you start the timer up here. Nathan, I want to start with you. Again, thank you. You helped me out in a jam once before, and I had you come and speak in Alaska.
That's true.
Which
Another
is far.
lunch keynote, as a matter of fact.
That's
so,
right.
Yeah.
State health policy these days really seems to me to be primarily led by the agencies. It seems to me that there's a lot happening, and some legislators would argue that it is outpacing the legislative mandate. Some legislators would argue that that's not relevant. The policy and the work that is happening at state agencies, Healthcare Authority, DSHS, Department of Corrections, Department of Labor, that all that stuff is really good, and it's earning applause or reinforcement through the CMMI grant and hopefully the CMS waiver. How do you respond to that notion that the Healthcare Authority is driving health policy in Washington State?
Sure. Well, thanks again for having me. It's a real privilege to be up here on the stage with decades of health policy leadership and leadership that I grew up under when I got to serve in the state Senate for a brief period of time. Okay, I'm still waiting. Okay, that's a fair comment. What I'll say is I certainly appreciate, both from my prior experience and ongoing experience, who the true policymakers on the stage are. And it's not the agency heads or executives that I get to work with across agencies on Healthier Washington. It's the legislature. They're the policy-making body. But when it comes time to execute, oftentimes on far-reaching policy, oftentimes policy or statute that's established without all of the specifics or logistics fully worked out, there's a lot of what I would call small p policy making that has to occur. I think what is nice about this time period is much of the work, whether we frame it as Healthier Washington or the broader health transformation efforts occurring in this state, it's informed by now 3 years of investment in the legislative process and in the stakeholdering process, first arriving at a 5-year healthcare innovation plan with over 1,000 stakeholders participating in that effort. Next, coming in the form of request legislation that was passed in a bipartisan manner in 2014, further follow-up legislation in 2015, and now the benefit of operating under a state innovation model grant, which binds us to some of the deliverables, both those deliverables that the statute explicitly laid out, as well as those that were more broadly defined and which are being laid out in more detail through the process that's underway. So I think at Healthcare Authority, we certainly appreciate, and I know our colleagues across state agencies, where policy gets made in the state, but we also understand our role as a health purchaser and as a leader in the health transformation space for making things happen once that policy has been established. And I'd like to say we're walking that fine line and being mindful of that tension in everything we do.
So, Senator Parlette, sometimes, I feel like the police sergeant in the movie Casablanca, when they are busted, and he said, I'm shocked that there's gambling in this establishment. I'm shocked that there's politics in health policy. Turns out that not everyone shares Nathan's perspective. I know Representative Schmick has been mindfully, has offered some observations about where he thinks the agencies are getting a little bit ahead of their skis. What are your thoughts as Majority Coalition Caucus chairperson when you hear Nathan talk about small p versus big P in policy?
Well, I would say that sometimes legislators take the lead on policy, but sometimes the agencies do too. And I think the State Innovation Grant, I mean, I remember the big thick binder was a big step to make, and it is controversial. Part of the bills that were passed in 2014, like 2572, I voted no on. 6312, with the integration of behavioral health, mental health, and eventually physical health, I support that policy. Whether we can get there by 2020, I'm not sure. So I would say yes, there is a tension, and the way I deal with that, because sometimes when we, having co-chaired the Behavioral Health Task Force, I can't seem to get the answers, and sometimes I found answers from the Healthcare Authority to be different than DSHS. The way to resolve it is to invite people to my district. So as we form a BHO, Behavioral Health Organization, in Chelan, Douglas, and Grant County, all 3 counties can ask questions at the same time and hear the answers at the same time. Because sometimes it feels like from day to day, we're kind of figuring out which way to go.
Representative Cody, what do you make of that? Is that your take as well? I mean, to a certain degree, you got to be flexible to let the healthcare authority kind of figure out how to implement some of this stuff. On the other hand, you know, we're talking about a $3 billion ask now and fundamental transformation of at least Medicaid, but also perhaps beyond.
Well, I think that the healthcare authority is just moving to get forward on really the policies that the legislature has been passing over the last, oh God, I don't know, 10 years probably. If you look at all the different things that are getting pulled together, that's what I have felt like the transformation in the SIM is working on. I mean, if you look back on, I think of like all the data that we have and that we've collected in the state through different things. And really, the state has been a leader in a lot of ways in that regard. But I don't think we have developed a good way to be able to get it down to the front lines and the providers so that every community, and this is, I guess, my vision and when I think about the SIM grant, is that the communities will be able to look at all the data that we have and know that suicide is higher in their area or teen pregnancy is higher, and really start focusing on those issues and be able to do more of a population management approach to their health care, and as a community join to realize what their needs are and be able to focus on it. So that I guess it's a big, I do think it's very ambitious, but I've been excited to think that maybe we're going to be able to get across the state some of the vision that we've had that has been developed in small portions.
So, Representative Cody, pardon me for not knowing this, did you come to the legislature in 95?
95 in my first session, yeah. I was in the minority, remember?
Yes, yes.
I have been in the minority, I got to remind people.
The gentleman, former speaker from, I believe, your district, Senator Parlette, at the time.
Yep.
Yeah. You know, you're a nurse, work at Group Health, now chair of the healthcare committee for 14 years-ish.
More.
Didn't you, yeah, you count the dual role period there for a while too, right?
Yeah.
Why haven't you solved this yet?
You know, I go back to work regularly and say, I wish somebody would figure out what the hell's going on around here.
There ought to be a law.
Because somebody should fix this mess. I do say that regularly. And you know, I wish I could answer that question.
That's probably the best way you
I
could
can only
answer.
say that I keep trying. That's what I'm about. And you know, I will say that I think being a provider has been helpful because I run into the problems and say, oh God, this is still a mess and we have to take care of it. You know, so that's, if you look at through the years, some of the different things I've worked on, it's probably been whatever the problem was the worst that I had to deal with at work that year.
So I wonder, though, looking back on those halcyon days of 1995, when, particularly January of 1995, Washington State had a, for better or worse, relatively comprehensive health reform package adopted at the state level. The federal government was deep in a conversation in 93 and 94 about that. That stopped in 1995. But how would you gauge the progress of Washington State, considering where you were in 1995 with where you are now? I mean, this will never be a problem that is solved, but do you think that you made as much progress as you would have hoped when you first joined the legislature in 95?
I would say that we are, yes, on the right track now. We've had some, I guess what I thought when I got elected in 95 that I was going to come down and help tweak the healthcare reform that had been passed. See how naive I was in 1995. And it's just taken until 2015 to be able to do that. That's all.
Yeah. Senator, we have a citizen legislature. And if health policy is the most complicated, in my view at least, subject area, it's very difficult for citizen legislators to get their hands around some of this nuance. But you've been working on this for a long time. And you've already expressed sometimes there still remains confusion about how policies will be implemented. How do you take 2572, 6312, those bills in the direction that the state is heading, and bring that content home and share it in north central Washington, your district, where there have been a lot of challenges in the mental health system. You have also a very dynamic medical provider there. How do you act as a bridge between the world of Olympia and the world of Chelan Douglas?
Well, I'm very engaged at the local level. I've been paying attention to Chelan Douglas RSN since I was a new legislator. My first year was 1997. And I do sit on the ACH board. So being a rural legislator, you run into the people at the grocery store and so forth. So I just feel like I'm very connected with my community. They know why I voted the way I did on whatever bill it is. I don't think it matters how you vote, just so you know why you voted a certain way. Sometimes I'm right, sometimes I'm wrong. But I can tell you, as a freshman, my first 2 years, we were in the majority in 97 and 98. And then we had the tie. And Representative Dyer had retired. Representative Backlund, who had hoped to be chair of the Healthcare Committee, lost. Another Republican lost. Bottom line, there were 2 Republicans left on the Healthcare Committee. And I remember my seatmate, Speaker Ballard, probably around December 20th, it was so late, called me and said, I would like you to be the co-chair of the Healthcare Committee. I wish you had more experience, but people trust your judgment. And I guess I would say by just being a pharmacist, being active with my community, I had those relationships in the healthcare area, but I certainly learned a lot just because we had the individual market reform. And Eileen and I had so much fun. I mean, at one of our very first meetings, I gave her a helmet, and we each put these helmets on because everybody didn't think that 2 strong women could get along. And we had so much fun. And anyway, so I'm rambling a lot, but the relationships that you build, whether you agree or you don't agree, how you come together to solve the issues is really what counts. And Eileen and I have just had years of fun. And we've always said, if you and I agree, we probably can solve this issue. And we've had a lot of them that we have.
Yeah. So Nathan, Senator Parlette mentioned serving on the ACH board. There was a comment last night at our dinner. A gentleman said, look, I'm an observer of innovation. I watch it across multiple sectors. And the best innovation flattens the user experience. It makes things more efficient. It takes out layers. The ACH, the Accountable Community of Health, is a new layer in healthcare. It's moving in the opposite direction of that gentleman's observation about innovation. How do you argue against that notion that where markets often work, they often lead to more efficiency?
Great. It's a great question. I think one of the greatest inefficiencies observed by those communities, many of them represented in this room today, is the siloed thinking with which we've approached healthcare transformation previously. Maybe they're more vertical layers than horizontal layers, but we have a lot of very well-intentioned people and organizations trying to make care better for very vulnerable populations, and oftentimes not talking together about how to do that. So if Accountable Community of Health provides nothing else, it provides a table where sectors within a community can actually have those discussions around how to tackle very difficult issues, whether it is teen pregnancy epidemic, whether it's obesity, childhood obesity in particular, whether it's early childhood trauma that's experienced, as many of and several of our ACHs have been tackling so far. I would push back against the notion of this another layer idea, largely because what I've seen already developing in the norming and forming stage of ACHs is real community cohesion, understanding with what limited data they already have, what the needs are, and getting together sometimes for the first time across these regions in the same room to talk about how the resources that are at that table are going to be brought to bear on the problems at hand. I can appreciate at the same time the problem statement of not needing another layer, and I think we have to ensure that accountable communities of health become very meaningful infrastructure that empowers health transformation and not a layer, governmental or otherwise, that gets in the way of it happening. And so I see it as an effort that is removing some of the silos and layers that have prevented health transformation from moving forward in the past.
So the MCOs, the Medicaid managed care organizations, are accountable by way of contract to the healthcare authority. Accountable communities of health, who are they accountable to?
They're accountable to their populations. That's who they're serving. Under
But
the
how will that mechanism work
Yeah,
where the population
sure.
can provide feedback that can direct action based on accountability?
That's a very good question. First, I'll say under the State Innovation Model Grant, programmatically for the dollars that are being used to set up ACHs, the Healthcare Authority is the ultimate authority over how those dollars are spent. But of course, Accountable Communities of Health are a lot more than a grant program. They've come together in each of those communities very organically. And each of those communities has a different process for engaging consumers and the broader populace. Many of those Accountable Communities of Health engage their local elected officials. Senator Parlette mentioned she serves on the board of the North Central ACH. So there are actually a variety of approaches at the community level that really meet the community needs for ensuring that they're listening to the population health needs that exist. And again, I think this is a critical and really one of the first major steps this direction. One of the great challenges we have, you mentioned the contracting effort that we have. We are a health purchaser. We chiefly buy health services through contract. One of the challenges, we often don't understand or hear how it's actually taking place, how health services are being delivered, and the performance of the delivery system overall. And already we've seen Accountable Communities of Health being very effective champions, both for things that are going well, as well as things that are not going well. And in addition to that, when you talk about one of the key legislative mandates that was alluded to, physical and behavioral health integration, and both at the financing, administrative, and care delivery level. This is no small task, and 2020 is an ambitious target that I hope we're going to hit, Senator. But you have to have more than just a state and a managed care contract intervening to make that happen. And I've seen our Accountable Communities of Health already stepping up in a big way to ensure that integration becomes a priority at a community level.
So on the question of integration, Senator, some would argue, the Healthcare Authority would argue that the current statute is clear. RSNs, BHOs will roll into mental health purchasing will be jointly purchased, or there will be a financially integrated purchasing model for mental health and physical health, meaning the RSN will roll, or BHO will roll into the MCO. At least one prominent member, Senator Hargrove, says that legislation's not clear and there's no requirement that counties will roll in. Do you have an opinion on whether that is clear in the statute, that integration will happen, and that was the purpose of 6312, or do you think that that is an open conversation still?
Well, I do think it's a goal, and I thought the legislation was clear. The question mark is if we'll really make it by 2020. We'll have one early adopter, we'll have some middle adopters. The big challenge is, will the state in the contracts make the rates work so we have a sustainable system? I think that's what everybody's worried about, especially on the chemical dependency side. That was the #1 recommendation that came out of the Behavioral Health Committee or Task Force to make sure the rates work. So it is a lofty goal. It has to be sustainable. I mean, we are asking healthcare entities, some of them, to change their business plan. That's a really scary thing. And they need some certainty that this really is going to save money and that the rates will be there to make this work. That's the big question mark. Yeah. We also have some legislators, as far as the Accountable Communities of Health, feel that 2 pilots were authorized, but somehow the Healthcare Authority is letting them operate all across the state. That's a question. We'll see how that ends up. But I think the ultimate goals are good, very ambitious. Time will tell.
Yeah. Representative Cody, let me shift gears a little bit.
Except I want to say it's 2020.
It's
It's
settled.
in the statute.
Right.
I don't care what Hargrove says. It's in the statute.
Well,
he's already heard that from me. So.
Yeah. He has an amazing capacity to not listen sometimes.
Yeah. I told him you said that.
Yes, yes. So sometimes some counties adopt this model and they say, yeah, great, Clark County, Skamania County, they're all in, they'll be early adopters. Sometimes counties, and I think Senator Hargrove is reflecting some of the concern of his constituency and his counties in the harbor area. Some counties don't want to move quickly, and they are concerned, primarily because the RSN community doesn't understand their role in an integrated purchasing model. And some RSNs in the state are, at a minimum, slow walking, and in some other cases, I think, in my view, actively working to maybe mitigate through stalling. One, do you see it that way? And two, how are those politics of counties and RSNs influencing this policy that is really centered around whole person care?
Well, I would say through the years, I've had my arguments with the counties over mental health, providing mental health and their role and whether they're, how things are going. But at this point, I believe that the counties are actually moving forward, that they understand the first, now in 2016, that there'll be behavioral health organizations and that's getting worked out. I think the biggest concern is the rates, and also that I'll just put my plug in for my own bill, that we need to be doing something about secure detox, because the counties are realizing that they're providing secure detox, only it's called a jail, and that is not the way to deliver services, and so that we need to move forward on that, because we don't have any beds in the state that are considered secure detox. So that's one of the issues that I think that the counties are recognizing, that this is a good way to move forward in the mental health and the chemical, becoming a behavioral health organization and getting a better handle on how to deal appropriately for different populations, detox being a big issue. And what was the rest of it?
I got another one lined up for you.
Oh, great.
So Nathan, let me just make sure I remember correctly. I always forget, just in the confusion, is it 1.2 Medicaid beneficiary, 1.2 million or 1.8 million? Just what is the number?
Because you asked, it was 1.2 million before the Affordable Care Act.
Great.
It's 1.8 million now.
Great.
And as a result, we've reduced the uninsured rate by 2/3 in the state.
That's right.
And since Pam McEwen and Molly Warris aren't on the stage, is it 173,000 members in the health benefit exchange, qualified health plan enrollees? Not quite 200,000, I don't think, but I know Pam will correct me later. Representative Cody, shouldn't Medicaid and its 1.8 million people be paying more for the exchange, since they are getting 1.8 million beneficiaries enrolled? And the QHP model is only 173. Shouldn't the HCA be contributing more of its budget to support the exchange?
I think they negotiate. I think they should pay their fair share, and I thought that was what was calculated last year, and why, because I know Representative Schmick and I both agreed on, this was like things we were agreed on last year, to make sure that the Medicaid was paying their fair share. So that was the number that was given to the legislature. Am I wrong, Nathan?
No,
but the number in the $123 million budget that the exchange has, I think that number is in the 10 million range. And so if you have 1.8 million beneficiaries, it seems like there's a lopsided 1.8 versus 175, but maybe 10 to 15% of the budget comes from Medicaid. I ask this because the exchange, and I know, Nathan, you're sort of wanting to jump in. I ask this because the exchange has had some shots taken at it from the legislature, and the exchange would argue, hey, Medicaid should pay its fair share, and 10 million is not reflective of the relative enrollment from the two.
Well, I'd say that the exchange has to show us how they're not paying their fair share. And that was one of the difficulties that we had last year, was getting, because it's not a public agency, it's a public-private agency, the legislature was not getting the budget that defined to us the way we wanted.
Yeah.
I think that is getting resolved because of things that we passed in the budget last year and some of the bills that were done. I know Senator Becker and I have talked, and that we're much happier with the way things are coming with the exchange at this point. So we'll see what happens this year.
Yeah.
But DJ, I would add, I mean, the budget that we will be facing in 2016 is off balance now because of the underestimating caseloads. I mean, both the SHS and the Healthcare Authority, the numbers that were in the budget that finalized 2015 were off base, and therefore we're going back with some deficits that we have to correct because of the 4-year balanced budget requirement. But I don't think that had to do with the exchange.
No.
I would just add that From a Medicaid perspective, we want to pay our fair share. It's actually very advantageous to the state budget to leverage the federal match that's involved with any Medicaid allocation to help benefit exchange expenditures. And I think it's our view that we've really leveraged to the fullest extent possible the allocation opportunities for the HB budget. And remember that for the roughly 1.4 million actually of Medicaid beneficiaries that are accessing their coverage through the exchange, they're not using all of the exchange's services, unlike those accessing it for qualified health plan purposes. So there are differences. And again, our interest is to pay our fair share, absolutely, and to figure out ways, if there are ways of being more creative, to figure them out. And I think we have a track record of doing that, both for the exchange, but as well other areas where Medicaid cost allocation is involved.
So my two personal friends, Kevin Quigley and Jane Byer, are no longer, or one has left DSHS, one is on his way out, announced his retirement here earlier this week. We noted in one of our email newsletters, 5 Things We're Watching, that one of the HCA budget requests was to get, I think, 3 FTEs specifically to provide better oversight of DSHS mental health services, which I thought was interesting and a manifestation of sort of the next step, perhaps, of an ongoing relationship with some creative tension about how integration should progress. Maybe speak to that to the extent that you want to bring those agency relations to this audience, but maybe alternatively, how hard is it to be tasked with being the Medicaid agency, hold the contract with the federal government, tasked with integration of mental health services, but not be able to guide the mental health program or funding?
Sure, there are challenges, and many states face similar challenges in the way they're structured administratively. I would say that the particular budget request you're referring to is more a reflection of increasing federal scrutiny on state Medicaid agencies. There can only be one single state Medicaid agency under federal law, and it's really their demands of our single state Medicaid agency in terms of what we are practicing oversight over. And so those FTs were requested to assist us in that activity. Not so much a suggestion that we're having difficulty working with our partners at DSHS. I think they would be themselves very supportive of the same request, understanding our responsibilities under the federal law. They practice oversight over things we do, and we certainly practice oversight over things they do. So it's a relatively fair exchange. But there are challenges, and those challenges are both at the community level with regard to how we administer and finance physical and behavioral health care, as well as at the state agency level. But that's something we're managing on a daily basis.
Senator, I think of you as a doer, a workhorse, not a show horse, and willing to point out where people, regardless of rank, party, or file, so to speak, are doing good things and maybe not doing good things. What has Governor Inslee done well on healthcare in your view?
He signed the bills that the legislature passed that allowed telemedicine. The credentialing bill, 5557, finally we have pharmacists credentialed in the state of Washington. So much education that will help bring down the cost of health care. I don't think health care is his passion. I seem to remember something about climate and carbon and things that he talks about a lot. But his staff has been good to work with, but I think this is a case where the legislature has led more policy.
Representative Cody, I find you to be somebody who is open-minded, willing to be critical and complimentary of people, regardless of rank, party, or file. I thought I would ask you, what is Governor Inslee doing very badly on health policy?
Badly? Well, no, I'd actually just parrot exactly what she said. It's not his priority. It's clearly not his priority. And that climate change is what he focuses on. And boy, what more can I say? It's not, I mean, it's not, he stays out of my way. That's a good thing. So that's what I'll say positively. And he has not gotten in my way. That's how's that? I don't, you know.
So,
and now I'm in trouble with the governor too. Oh God.
Bob Crittenden, who is here.
I know, I saw him right there.
Who's special policy advisor for health reform for the governor, might argue, well, okay, he has signed the bills that the legislature has passed. Turns out those are pretty transformational bills. And we've, expanded Medicaid, and we've got the exchange up and running, and a lot of other states haven't. And if that's to the legislature's credit, which it is, I'm still waiting for that bill on McCleary, right? And there are other contextual things
Yes.
where it's easy enough up here to sort of push responsibility one way or the other. Where is the legislature, Representative Cody first, where is the legislature falling down on health policy, on health care?
Health policy. Oh, good. I don't have to get into
We are not talking about
education.
McCleary here.
Thank God. Well, I think that it's the mental health funding and the Medicaid rates. I would say that's probably our biggest issues. And it's again, it's money, because McCleary now is driving so much that I think that's definitely where, but mental health, our rating and the needs and assessment on mental health is abysmal. Finally, we're getting the hospitals to open up more beds, so that's improving. I'm hopeful that we're on the right track there. But and it's amazing to me because it seems like we've been working on it, forever, but we just haven't made much gains on it. We're just keeping up with ourselves is about what it has amounted to. But I just had to go back because I was going to comment on the agencies and divide. Yeah. Linda and I learned as young legislators, because when we were co-chairs, we had a bill that would have rearranged DSHS and healthcare. Remember, we were going to move things around, which is actually somewhat what's happening with the regions now and the accountable collaboratives of health. Was we wanted all of the DSHS things, long-term care, so that you wouldn't have a case manager in this region for long-term care and another region for Medicaid, how they all divvied up. So that's now lined up, but we learned Gary Locke wasn't interested, amazingly enough. And I think at that point, when people talk about how we should do something with the agencies, we learned you got to get the governor on board. It's the governor's executive policy on how the agencies are set up. So we just try and be helpful and give some directions and wait 20 years and somebody else will think it's a good idea. So.
Senator Parlette, I'll ask you the same question I asked Representative Cody about where is the legislature falling down? But I'll also ask this question because your comments, Representative Cody, make me think of it. Would it make more sense to roll the mental health DBHR and the mental health agencies into the healthcare authority? Cut that out of DSHS?
I guess what I would say is whatever works. Where I think we have fallen down, and yet it is a priority of Senator Hill, who is the chair of the Ways and Means Committee, and he's got this great background coming from Microsoft, is there is a real need for upscaling the IT systems in the state of Washington so we can have the proper data. Our systems are old, they don't talk to each other, and if we would spend the money to improve and update our IT systems, I just think that would allow us accurate data, not just in healthcare, but in a variety of areas, and in the long run, perhaps save the taxpayers' money so we'd have more money for education, mental health care, and other things. That has to be a priority. When we get these big things like McCleary and lawsuits and so forth, it doesn't put us into a position to always fund everything we want. But I know that is a priority of our Ways and Means Chair, and I think that's very positive.
So I'll ask each of you one more question. Nathan, to start, you're in an elevator. You're stuck with Senator, you're not stuck, you're with Senator Parlette. Sorry, you know better, or I should know better. And her answer is, well, you come see me on that. I know he does, yeah.
I ask that, he comes.
What are you asking for? Or put another way, what is the most important thing the legislature can do for the Healthcare Authority in the 2016 session?
It's a fair question. You know, the Healthcare Authority isn't coming in with request legislation this year. Naturally, most agencies are focused on the budget and the supplemental budget process. Senator Parlette alluded to caseload changes and changes to rates that are impacting the budget pretty significantly. So I think the first thing we would be looking for her leadership and others is on budget-related issues, especially tied to the Medicaid program. And then I would also mention that what we'd be looking for out of the 2016 session, largely because I anticipate the conversations will ramp up during session on the Medicaid waiver with CMS, be looking ahead to expenditure authority and other such things that may come this session or may come the following session to make sure the way is well paved for that to happen in pretty timely fashion, because things I think once we get to a certain stage of this negotiation will start happening pretty quickly. So engagement on that front, and in particular addressing some of the Medicaid budget issues that were alluded to earlier.
So Senator Nathan has come to see you in your office, and you say, okay, that's fine. Here's what I want to talk to you about. And you answer that how, or put another way, what does the Healthcare Authority need to do better to help you do your job better?
To give everybody some certainty that all these new changes are going to be sustainable. Because I think that is what the big worry is. If whether you're a MCO or a health insurance company or a big business that provides health care, in our area, Confluence Health does wonderful health care throughout the area. But to change the business model or whatever to adapt to new things, it's the payment reform. Will the money be there to sustain the new business model? I think that is the number one question. And you have that answer, don't you?
Right at the tip of my tongue.
Representative Cody, similar question but differently put. This group comes to see you in your office.
They all do.
And there's 15 minutes on the clock, which means you're starting 5 minutes late, and they have 30, 45 seconds to speak before you interrupt them and talk about what you want to talk about, having been in those rooms with both of you. What does this community need to do or tell you in 30 to 45 seconds to help you do your job better in Olympia? How can they help you?
Well, always come with just one thing on their mind and give it one page. That's why I tell everybody that. It's like you got to be able to say it in a short amount of time and make it simple enough that other legislators that aren't healthcare legislators will understand it. That's the biggest. It's one thing to sell something to Linda and I, then we have to sell it to the rest of the legislature. And that's, I think, the hardest part is to make sure that everybody thinks they know something about healthcare because they all go to a doctor at some point. But it's not quite the same as a health system and trying to get coverage. And so that's, I think, where we probably have our biggest difficulties.
Yeah. Three of the people whom I respect as much as I respect anybody in Washington State health policy. Nathan Johnson, the Chief Policy Officer for the Healthcare Authority, Senator Linda Evans Parlette, Majority Coalition Caucus Chair and Chair of the Health and Wellness Committee in the House of Representatives, Representative Eileen. Cody, thank you very much. Let's give them a round of applause. Thank you. Thank you for pinch hitting and filling in. We have 2 more sessions, same kind of format, and then we will see you here in the afternoon to close things out.